All right, everybody, thank you so much for joining this webinar. Before I introduce our speaker, just to say that if you have any questions during the talk, please feel free to type them into the chat. You won't interrupt the presentation and we'll address them at the end. Also, this is being recorded. A link will be sent out after the session. So, okay, on to our speaker. We are delighted to have with us today Henryk Barthel, MD, who is Professor and Assistant Medical Director of the Department of Nuclear Medicine of the University Hospital Leipzig in Germany. He underwent training in nuclear medicine in Heidelberg and in Leipzig. From 2000 to 2003, he was a research fellow at Imperial College Hammersmith Hospital here in London. Dr. Barthel's current research activities focus on new PET imaging techniques to improve diagnosis and treatment of neurodegenerative diseases, as well as on hybrid brain PET-MR imaging. To support the general progress of nuclear brain imaging, he served as chair of the Neuroimaging Committee of the EANM and serves as vice chair of this year's SNMMI meeting, as well as being the associate editor of the Journal of Nuclear Medicine. Thank you so much, Henryk, for fitting us into your very busy schedule and for being with us here today. And over to you.
Thanks very much, Elena. And I'm going to share my screen. Can you see the slide?
I can. It is not maximized. I can see the
PowerPoint. I will do it now. Yeah. So
great.
now
Yes,
it should
perfect.
be okay.
Yes, great.
Okay. Yeah. Thanks a lot again for giving me the chance to share with you my perspective on the future of nuclear brain imaging. Here are my disclosures. I will, after an introduction into the topic, discuss with you some recent advancements in terms of nuclear brain imaging technology. We'll then step into the exciting developments in terms of tracers we use for PET and SPECT imaging, how they are used in the clinic, and how they potentially will be used in future in clinical care, and in the end summarize and conclude. And again, I hope that you have some interesting questions, which we will certainly find the time to discuss after my presentation. These are exciting times if it comes to imaging neurodegenerative disorders, because currently we observe a paradigm shift in some of these neurodegenerative disorders. It all started with Alzheimer's disease, but it's now also ongoing in Parkinson's disease, and it will certainly also apply to other of these disorders in the future. So far, these disorders were defined as a syndromal construct, and based on that definition, they were diagnosed based on clinical testing, and this resulted in symptomatic treatment. So no curative treatment approach was so far available for these disorders. This potentially will change in the future, because there's now this idea of defining these disorders as a biological construct, and PET imaging and some other biomarkers are in the future used to diagnose these disorders. Here an example of how certain proteins like tau, beta amyloid, alpha-synuclein, and DTP43 can be imaged by PET. And this will hopefully in the end be followed by a specific etiological treatment to cure these disorders or even prevent them in the future. So this is really a paradigm shift, and for Alzheimer's disease, we apply these so-called ATN concept. So again, these are all biomarkers, or these A, T, and N category biomarkers are used to diagnose the disease. And again, this is now independent from the question of whether symptoms are present or not. A stands for amyloid, which can be either imaged by PET or measured in CSF or plasma. Tau is also measured in CSF or plasma or imaged by PET, and neurodegeneration is currently imaged either by structural MRI or by FDG PET, and total tau in fluids like CSF or plasma is also used as a neurodegeneration biomarker. And one of the main advantages of this approach is, as said before, that as it is independent from the question of whether symptoms are present or not, it can also diagnose the disease in a prodromal stage, so in a stage in which no symptoms are yet evolving, and thus this gives us a huge a new window of opportunity, providing an early diagnosis of Alzheimer's disease to also apply certain drugs even before the symptoms occur. And by doing so, we have for the first time the real chance to even prevent the occurrence of symptoms. So this is a wonderful concept, and it looks like we will soon see this concept really entering the clinical arena, but because there are some so-called anti-amyloid antibodies available and will be available to treat amyloid pathology in Alzheimer's disease. Two of these antibodies are currently in discussion. One is called lecanemab, and the other one is donanemab. Lecanemab has been approved already for clinical use in the States by the FDA, and it is currently considered for approval by the European Medical Agency for clinical use. Donanemab will hopefully also be approved soon. These antibodies, as said before, they are able to dissolve certain forms of amyloid aggregates in the brain, and by doing so, they also have a clinical impact. And the exciting news is for us doing nuclear medicine imaging is that amyloid imaging, specifically amyloid PET imaging, allows to not only monitor the effect of these drugs on biological grounds, but also to qualify the patient for the treatment. So we are really living in exciting times if it comes to imaging Alzheimer's disease, because we are now on this transformative step from drug testing to drug prescription in the clinical routine situation. There is this other ongoing discussion on whether it is competition if we talk about imaging biomarkers and so-called fluid biomarkers as obtained by either blood sampling or CSF sampling, whether this is a competition or whether there is additive value complementing each other. One idea we have published recently how both types of biomarkers, so fluid biomarkers and imaging biomarkers, might complement each other is shown here. We think there is a great chance to apply blood testing for Alzheimer as a screening test, as a first step test. And this can easily be done because the test is cheap and less invasive in many people, even at a certain age in healthy people which are still not suffering from symptoms. And then the idea would be that only the ones who are positive on the blood test might be candidates for PET imaging, which is obviously then able to confirm the presence of certain pathologies in the brain, like Alzheimer plaques or tau aggregates. And again, this combination of a screening test and a confirmation imaging-based test might even be suitable for screening even in healthy people, for instance, subjects at risk for Alzheimer's disease or subjects at a certain age. So what is currently going on in terms of PET imaging technology? And today we are just discussing brain imaging. There are some exciting technological advancements currently ongoing. One is related to dedicated brain systems. We also observe better scanner technology, which allows us to image the brains in higher resolution with a higher detecting sensitivity. We also observed improved technology in terms of image reconstruction and motion correction. I've shown here as an example FDG PET images as have been obtained in our department here in Leipzig over all these years by using, in this case, 4 different scanners. And I hope you can acknowledge the fact that step by step we are really getting better in terms of resolution, and the images are getting much clearer in better contrast, again with a better resolution. And the hope, of course, is that we, by doing so, also increase the diagnostic accuracy of what we are doing. The other concept is related to the already mentioned idea of increasing sensitivity of the scanner, which in principle would allow to, in the future, either reduce the scan time or reduce the tracer dose which we apply to the patient. This newest generation PET scanners, like for instance the Biograph Vision Quadra scanner, for instance, allows us now to get a brain PET out of a 2-minute scan only. So even in patients who have limited ability to cooperate because of their dementia symptoms, for instance, they are now able to undergo the scan because it only takes 1 or 2 minutes, which is really a fantastic improvement in terms of comfort to the patient. So what is the concept behind this idea of developing brain dedicated PET scanners? There are different ideas, and one is related to the concept of even further increase the image quality and the resolution, which would allow us to, in the future, image smaller brain lesions, but also get a better earlier diagnosis by doing so. And the other concept is really to have cheaper scanners or smaller scanners, which require either less costs in terms of distribution and acquisition and running of the system, or even less space in the PET suite. Most exciting is certainly also this idea again of further decreasing the scan time or the tracers dose. So we see that such a new concept might even be cost effective in the end, because you would need to buy a less tracer in the future. Here a figure of a publication by Ciprian Katana from Harvard, published in 2019. At that time, he very elegantly summarized what was going on 5 years ago in terms of development of dedicated, so brain dedicated PET systems. Some of them are shown here, and some of them are even mobile, and that is quite interesting also for research applications. In the meantime, other projects started. We in Leipzig have an interesting collaboration with a company called Positrigo. They are based in Switzerland, and they are developing this neuro LF scanner, for which the design strategy is to develop a compact and versatile scanner, and we will soon be able to test this scanner in a first human non-inferiority proof of concept study. So far, phantom measurements were carried out. One example is shown here of a Hoffmann phantom, which according to our impression really is very promising in terms of image quality and acquisition parameters. So we are looking forward to hopefully show you some clinical human results soon. So if it comes to amyloid imaging, what are the traces we are currently applying to image amyloid pathology in the human brain? There is this research or carbon-11 labeled PIP tracer, which obviously because of the nature of the label can only be used in PET centers which have an own cyclotron. The other tracers, the fluorine-18 label tracers, 3 of them are approved for clinical use, like florbetaben, flutemetamol, and florbetapir, can obviously, because of the longer half-life of the label, be ordered and shipped to your PET site. In terms of diagnostic potential of these tracers to diagnose Alzheimer's disease, the common understanding in the community is that all of them are of excellent quality and excellent diagnostic capability. This is echoed by a recent meta-analysis comparing 2 of these tracers, florbetapir and florbetaben, in terms of sensitivity and specificity to diagnose Alzheimer's disease based on a large number of clinical studies. And again, very nice, very high sensitivities and specificities without significant differences between the 2 tracers investigated. Currently, the common sense on the appropriate use of these amyloid PET tracers in clinical care is that it should be applied or can be applied in patients with persistent or progressive unexplained memory problems and impairments. This is typical so-called MCI or mild cognitive impairment situation. Another scenario are patients which already are demented, in which the clinical presentation is not 100% typical for Alzheimer as the underlying disorder causing the dementia. This would also qualify a patient for an amyloid PET scan. And scenario number 3 is patients with dementia at an unusual early age of onset. In the future, and these appropriate use criteria are currently undergoing an update process, and these updated AUCs will hopefully be published soon. Amyloid imaging will also be qualified as appropriate as discussed already, to qualify patients for prescription for anti-amyloid drugs. There's also already interesting data published on the clinical effect of applying amyloid imaging in a wider clinical context. And the main results of this so-called IDEA study, which was published in 2019, is that in about 60 to 65% of the patients, regardless of whether they suffer from a mild cognitive impairment or dementia, will, by doing an amyloid PET, see an overall change in the management. In most of the subject relates to change of Alzheimer drugs prescription. So the typical scenario is that the neurologist thinks that this is Alzheimer's disease, but the patient is amyloid negative, so the clinician will consider other treatment approaches. In some of these patients, also the amount of counseling was impacted by the amyloid scan. So this is convincing preliminary data on the clinical benefit of the patients. What we are currently trying to establish is more clinical evidence on the actual outcome of the patient after an amyloid scan. So this is missing evidence, which we will hopefully be able to see soon. I, as a medical doctor without any background knowledge on economics, apart from my normal school education, try to think about a business case doing amyloid imaging in Alzheimer's disease, and I'd like to share with you my calculations. One scenario I have investigated, and this is really the application of a disease-modifying drug. So, for instance, lecanemab, which is, as we have discussed already, an antibody against amyloid plaques. If we just think about Europe, we have a prevalence of dementia in people older than 65 years of about 10%, and about 5% of these subjects suffer from Alzheimer's disease. If we now consider the fact that we have in Europe a population of about 150 million people older than 65 years, this will come to about 7.5 million Alzheimer patients in Europe, which is an amazing number. So just based on this theoretical idea of that all these patients might be candidates for a drug like lecanemab, we would need the according number of amyloid scans. And if we assume that a PET scanner can do about 50 patients a week, this would make 2,500 patients a year, and this would require, if I'm not wrong, about 3,000 PET scanners in Europe to scan all AD patients within 1 year. This is just to give you an impression on the extent of the problem. If it comes to a new drug being available, and this would of course also require that all of the patients will undergo amyloid PET imaging to qualify for the drug. In Europe, it will probably be like that these antibodies like lecanemab will potentially be approved based on the fact that amyloid PET imaging and CSF sampling for amyloid can be used to qualify the patient for the prescription. So not all the patients in Europe will undergo amyloid imaging. But again, this is just more a theoretical calculation to show you the massive need for more PET scanning capacities in the future if these drugs are coming. And of course, we also need, if we want to scan more patients in terms of amyloid and other tracers, we also need better tools to get a better diagnosis. And one idea is related to software tools which are able to give you now in color not the amyloid load, but the deviation from the norm in collective. So you have your PET scan of your patient, and then you have a normal database, and the software will voxel by voxel compare the tracer uptake in your patient against that of the normal database, and it will in color give you brain areas which deviate in terms of the normal database. These are examples here from a patient scanned with FDG, in which here these voxels of deviation, in this case decrease of activity, are shown in the typical Alzheimer regions of the temporal parietal areas mainly. And these are two ways to show these results, either to project these Z-scores, so-called Z-scores, onto the surface of the brain, or show them slice-based. So for both approaches, software tools are quite helpful and available to analyze your PET data. And this will not just be a visual impression, but also a quantitative outcome. So you have the tools to get these Z-scores. Again, these are numbers for the deviation of the tracer uptake from the normal area, normal range in all the brain regions of interest. There's also this concept of more advanced image analysis, for instance, applying artificial intelligence, or as a in-between step, applying so-called principal component analysis. One possibility is a project by Dr. Leenders in Netherlands, in which FDG PET data can be analyzed, and you end up with a number for your brain for FDG PET, and this number gives you the likelihood that the patient suffers from a certain disease. So you get a number for instance, Parkinson's disease or MSA or PSP, and then that helps you to get a better differential diagnosis. So this is also I would say an interesting development, getting more and more automized in terms of image analysis and diagnostic support. So today if we talk about nuclear brain imaging, as you all know, we use dopamine SPECT to image patients with Parkinson's syndrome. We use FDG PET mainly in differential diagnosis in dementia disorders or movement disorders. Many of us employ amino acid PET imaging in brain tumors. Some of us FDG PET in epilepsy imaging, and some other applications. And in the future, I see huge potential for the already discussed amyloid PET imaging to diagnose Alzheimer's disease. Also a great potential of tau imaging in the future, again in Alzheimer's disease, but also in other tauopathies in the brain. Excuse me. There's also this huge hope that we sooner or later will have an alpha-synuclein PET tracer available. Alpha-synuclein is the primary pathology in Parkinson's disease, for instance, and that would, the availability of an alpha-synuclein PET tracer would certainly stimulate early Parkinson diagnosis, and hopefully also decision making in the future in terms of specific treatments. The application of amino acids to image brain tumors will, for my prediction, also flourish in the future. And we will also still do a lot of epilepsy imaging, dementia, and movement disorder imaging with FDG. There might other potential applications come in the future, like, for instance, imaging long COVID by means of PET tracers. So in summary, I hope I was able to share with you my excitement on this topic. And there's this, to summarize this interesting evolution of nuclear brain imaging technology in different directions. So either employing more advanced scanners to get even better images and better diagnosis. And on the other side, to employ simpler and cheaper scanners to just be able to offer this technology to more patients in the future. Together with that, we are step by step using more advanced image analysis tools. Of course, we are also using more advanced PET and SPECT tracers. For the sake of time, I did not talk today about PET imaging of tau aggregates, but this is certainly also one example of exciting new developments. And together with these Alzheimer drugs, which will hopefully be applied in clinical care soon, we hopefully will also expand our portfolio and capabilities of doing more clinical imaging. So altogether, I think that the future of nuclear brain imaging is bright. And with that, I thank you very much for your attention. And I'm happy to take questions.
Thank you so much, Henryk. That was a really interesting talk. And please, anyone from the audience, please feel free to type in questions to the chat if you would like, and we will target Henryk with them. Perhaps I might ask a few questions to start us off, if I may. I loved some of those brain-specific PET scanners that you showed, especially those sort of helmet, hat-style ones. They looked really cool. My experience, so a hospital that I used to work in had a dedicated scanner for breast. And what we found was that it was really difficult to maintain it, because if you only had a few patients, trying to keep up all the QA schedule and to make sure that it was serviced regularly just didn't feel like it was worth it for a small number of patients. So it seems to me that you really need to demonstrate that you have enough patients, you know, several patients a day almost, to have a scanner like that. Do you think that's true? Is that what we need?
No, I fully agree. We are step by step all required to set up a convincing business case if we want to get funding for new equipment. So
Yeah,
it's, I fully agree. Yeah.
If
But
those
there's really
3,000 new
this.
PET scanners that you predict are required,
Yeah,
then hopefully it
well,
should
I
be
mean,
fine.
yeah, yeah. No, it's just that, yeah, these numbers. I was trying to explain that this is just my personal calculation. I'm not sure whether it's scientific valid, but to demonstrate this huge potential. So once we have these anti-amyloid antibodies, for instance, to treat Alzheimer's, and once we can use amyloid PET to qualify the patients for the drugs, this question refers to so many patients that I'm optimistic that we will have justification for dedicated scanners. Yeah.
I really hope so. I know there was a recent breakthrough with the FDA approved drug for Alzheimer's. My limited understanding of the efficacy of that drug is that it's actually really small, the improvement change that you see. I don't know if that's true, but then if you only can demonstrate a small improvement, perhaps the kind of cost that would be needed for these maybe screening programs that you talked about, it's more hard to justify that. So do you think it really needs to come from the drugs available for treatment before we can see big improvements in diagnosis and more big numbers in diagnosis coming through?
Yeah, thanks for this question. There's indeed a discussion ongoing on whether the clinical effect of the drugs justifies these huge efforts. Yeah? These drugs will be very expensive. They will also have side effects. So this is really an open discussion. I mean, in the clinical studies which have been performed testing these drugs, the clinical benefit was highly significant. But I fully agree, for the individual patient, it might be limited. My other hope is that the clinical benefit of these kind of drugs might even increase the earlier we apply the drug to the patient. So one idea is that if you are already demented, then it might be too late to apply this drug. So one idea is to give the drug before the symptoms occur. Yeah, and this might be much more effective in terms of clinical outcome. Yeah.
That does sound good, and I am optimistic too. I don't want to bring down the optimistic tone.
Right.
I hope so. I was going to ask you, thank you for showing some of the software images there. It was a nice description of the Hermes Brass Z score visual reporting that you can use. I wonder, do you think that having software that can give you this objective measurement of whether or not of treatment efficacy, so whether it's a Z score or whether it's perhaps this new Centiloid scale, is that something that can be used to convince regulators and to make a more effective or more reliable treatment efficacy measure?
Yeah, absolutely. I mean, it has been used in the trials to measure the biological effect of the drug. Yeah, and it's the best tool to do a PET scan and to measure centiloids in terms of amyloid. It's the best technology to answer the question of whether the drug is doing the job or not. Yeah, and as said before, there's also this idea of titrate the dose of the drug and also the duration of the treatment depending on the individual situation over time. So there's some evidence that these drug effects might differ from patient to patient. So PET imaging would be suitable to answer the question how the situation for the actual patient is. And again, as these drugs are expensive and have side effects, I see that it might even be cost effective to do follow-up PET imaging in these patients under treatment.
Sounds good. Perhaps I could just take us slightly off the topic of your presentation. I understand some of your research also includes theranostics for brain diseases. That sounds really interesting.
Yeah.
Perhaps you could tell us, is that anywhere near hitting clinical routine? Might we be seeing theranostic agents for brain-related diseases in future?
Yeah. Yeah. This is a very good question. Yeah, I mean, if we talk about theranostics in brain, I think there are currently two concepts. One is related to brain tumors, where you indeed have the concept, the theranostic concept, which is to have like a pair of two tracers. One is able to diagnose the disease and the other one is able to treat the disease, is more advanced than the other idea. So for treating brain tumors, there are currently a number of clinical trials ongoing applying this theranostic concept. And so it's not there, it's not in the clinic, but we are optimistic that there's one or two of these approaches might have the chance to enter the clinic. One concept I'm most excited at the moment is applying somatostatin receptor tracers to diagnose and to treat meningiomas in
right.
the head.
Okay, that's one of the other findings that you can see, I believe, on a dotatate PET-CT,
right.
sometimes
Exactly.
meningioma. Right.
These meningiomas have this massive expression of somatostatin receptor type 2, and that qualifies them, as said before, both for PET imaging and for treatment with beta or even potentially alpha emitting tracers. Yeah. And the
right.
other,
That would be amazing.
and the other thing is that we doing amyloid imaging and combine this amyloid PET with the application antibodies treating the amyloid plaques now also discuss whether this combination might also be considered as a theranostic approach. Yeah.
Right.
So the idea is to do more theranostics apart from oncology. Yeah, that's the new idea.
Sounds good. I have a couple of questions from the audience. So we have from Daniel Gundel. I'm very sorry for the pronunciation. Great talk. What about neuroinflammatory tracers in clinics? Are they helpful? And which are actually promising?
Yeah, Helena, we have discussed this question before the talk, yeah, so you can answer that. You know what I will answer. Yeah. I'm really excited about this potential of imaging neuroinflammation by PET. Yeah. These new generation neuroinflammation tracers, for instance, targeting TSPO, are really getting better and better. So despite the fact that we have this principal technology available for more than 20 years now, I still am optimistic that it might enter the clinical arena in the future. It all will depend on, from my perspective, it will all depend on whether therapeutic consequence will arise out of this scan.
Hopefully, I mean, you showed that very interesting evolution of the PET scans that you've been acquiring through the years, and TSPO tracer should really benefit from that increased sensitivity.
Absolutely.
So, yeah. Okay, great. Another question. This is from Alex B. How do you view the relative value of FDG brain imaging, amyloid brain imaging, and tau brain imaging with regards to dementia as a whole? Will the value of FDG brain imaging decrease in the future as these other more specific tracers become available?
Yeah, thanks a lot for this important question. We have been discussing this in the community for quite some time. We actually also published some papers on that topic. There are different opinions on how it will end up with FDG imaging in the brain in the future. The interesting fact is that if you apply these amyloid tracers and the same accounts to many of the tau tracers, you can do by so-called early imaging get, in addition to your amyloid or tau signal, also get a blood flow image of the brain. And this is very similar to an FDG image in terms of diagnostic information. So the trick is that you inject the amyloid or the tau tracer on the scanner and do a first scan, like 10 minutes. And then the patient leaves the scanner, has a coffee break, and then you do your regular amyloid or tau scan. And these early images are, we and other groups have published that, are a very nice surrogate for FDG imaging. So you have the chance by employing an amyloid tracer to get both the amyloid information and an FDG surrogate. So I personally love this idea, and we do it on like in clinical routine. We don't do much FDG anymore. We do a lot of amyloid and tau imaging.
Really?
Yeah.
That's
But
quite the opposite from the hospital that I work in the UK. We have lots of FDG.
Yeah, it also depends, of course, on the question, the diagnostic question. I mean, my understanding was that this question relates to dementia imaging. Yeah, if it comes to epilepsy imaging or encephalitis imaging, you still use FDG, or we still use FDG. It will survive, I would say, but maybe it gets less relevant.
Thank you for your answer. We have a question. Do you follow the layered scan approach by Professor Sabri?
Professor Sabri is my boss, so I have to follow. Otherwise,
Okay.
I will get in trouble. No, we have developed it just together. Yeah, we are a team
Excellent.
of research, and we have developed these concepts together. Yeah. Yeah.
Perfect. Well, I think we are through with the questions. People are commenting, thank you for the presentation, greatly appreciate the images and references. So yeah, thank you so much, Henryk. That was really interesting.
Thank you.
And yeah, thank you so much. Bye, everyone.
See you later. Bye-bye.